All right, looks like we're getting everybody back into the swing of things after lunch. Hopefully everybody got something good to eat or something to drink, and everybody feels energized for the afternoon. We've just got a really great slate of people coming to speak to us this afternoon. And we're going to kick it off with "That's Not What I Was Taught: Changes in Suicide Risk for Youth." And our presenter to kick off the afternoon is Dr. Shayla Sullivant, and I see that she has joined us. So this presentation is going to focus on emerging risk factors that were historically not a focus in youth suicide prevention work. The increase in suicide attempts and deaths among preteens and young women will be addressed. Alarming increases of suicide attempts among Black youth will also be highlighted, along with potential barriers to care. The elevated risk among sexual minority youth will also be emphasized, along with protective factors that could decrease their risk. The social determinants of health and how they relate to suicide in youth will also be considered. Just a bit of information about Dr. Sullivant. She completed undergraduate training at Creighton University and medical school at the University of Kansas, where she also completed a residency in adult psychiatry and fellowship in child and adolescent psychiatry. Since 2010, she's been on staff at Children's Mercy Kansas City, where she currently serves as an associate professor. In July of 2019, Dr. Sullivant was the recipient of the Shining Star Award for having the highest patient satisfaction ratings among the medical staff at Children's Mercy. Wow, Dr. Sullivant, that is awesome. She co-leads the suicide prevention research group at Children's Mercy and is completing research on suicide screening in conjunction with the NIMH. Her current work focuses on providing education for parents on ways to reduce suicide risk for adolescents, including safe storage. What a resume from somebody who has clearly devoted a lot of time and energy to this cause and to keeping children and adolescents in our community and around our country safe. So really looking forward to hearing what you have to say. Dr. Sullivant, it's all yours.
Thank you very much. Can you guys see my slides okay and hear me okay?
Okay. Sure can.
Awesome.
Sure can.
Very good. Okay, thank you so much. It's a hard act to follow after you do some mindfulness meditation and you get all relaxed. I've been in clinic some this morning, but I've tried to join and hear all of our speakers, and it's been really impressive. So I'm humbled to be part of this group, and particularly want to acknowledge the difficulty of survivors sharing their stories and thank them for it, because I think it constantly reminds us of why we are devoted to this work and why it's so important that we move forward. So thank you for being here. I do want to point out that the title of this talk is not meant as a criticism. The training I had at KU was top-notch. What I'm going to share today are some things that I have learned since my training, because as we've learned with COVID, science continues to evolve. And if we are going to stay on top of things and help our community, then we have to evolve as well with what we've learned. I also want to acknowledge, as everyone has done, this is a tough topic, and I specifically am going to talk about some aspects of suicide that are particularly hard to think about and talk about today. So I talk about safe storage or means restriction, which has already been talked about today, but I talk about specific methods that are used in suicides because we know from research it's one of the best ways to prevent deaths. And yet, I say that knowing that it is not easy to talk about. So if you have lost a friend or a family member to suicide, if you've had your own personal struggles with a patient, this can be very hard. So I encourage you to take good care of yourself in that. And just quickly, a little story. When I was in my training, I took care of a man who had all of the known risk factors. He was white, upper middle age, he had substance abuse issues, he was divorced, he was unemployed, and one of my colleagues took over his care for depression. And I learned months later that he had died by suicide. I say died by suicide instead of committed, because I think many people in the field feel like that is people aren't committing a crime when they die by suicide. We know that they're ill. And so when he died by suicide, I talked to a supervisor about it, who said to me, you know, Shayla, this is part of the work that we do. This is one of the really hard parts of it that we have to accept. And that was the main message I got. And while I know that that is to some degree true, I think we can do better. And we have a lot of room for improvement in this field. And that's where I get really motivated and excited to talk to a group like this. When I signed on this morning and I saw this large number of people, it just really made me excited, because when we band together and we work on this, I really think we can make headway. So just to get started here, I will go over first, let's see here, how are these gonna, there we go, the objectives. So we're gonna talk about, she actually kind of already went over the objectives, so I guess I don't have to read these again. I'm not gonna bore you with that. I first want to start with a quick story though about how we have to sometimes switch gears. So I don't know if any of you have tried to take a vacation during COVID. My husband and I last summer had this brilliant idea that we could do this safe vacation by just renting a house on a lake, and our kids could swim off the dock. And that sounded really safe. You know, we would cook and we would stay isolated. And so we get there, right, and we see the dock and we meet the neighbor, and we learn pretty quickly this isn't really a lake. This is more like a river off the lake. And by the way, the water's full of snakes. So you probably shouldn't let your kids get in there because it's full of snakes and it's not safe, right? And then we learned that when the new minivans have come out, they don't all have spare tires in them. They have a little tire fix-it kit in case your tire blows out in the middle of nowhere, Oklahoma. So this is my car getting towed, and I was told by AAA, just call an Uber, as if there's an Uber on every corner in the middle of nowhere, Oklahoma. So my husband really kind of redeemed this trip by finding for us an animal sanctuary, right, where my kids got to hold some interesting turtles, and it ended on a good note. But my point is that sometimes we go into something and the information we had at the beginning doesn't serve us, and we just have to keep learning. We have to keep adjusting our approach based on what we're learning so that we can do a good job for our patients, for our community, for our families. And so that's really what I'm learning in suicide prevention work, is some of the things that I was once taught are changing. So I want to go over some of those today. Now, I think we have to give a nod to the impact of COVID. This was a paper that came out recently. It's a meta-analysis. So this paper really is an overview of a bunch of different studies across the world, looking at how depression and anxiety have been changing for young people. And what it tells us in general is that 1 in 4 young people now are experiencing depression, and 1 in 5 are experiencing an anxiety disorder. These rates are double pre-pandemic levels. So we have definitely gone in the wrong direction. We also know from this paper that symptoms have been higher in girls and also later in the pandemic. Now, if you've worked in this field for a while or just been aware of the mental health crisis, you know that we had big problems before the pandemic, right? We had, as people were talking about earlier, the long waits, trying to navigate the system, trying to get in. I'm constantly getting phone calls from neighbors, friends, colleagues, physicians, trying to get help for their own family members and struggling to navigate the system. And it's gotten worse. So certainly there's a lot of work to be done. Now, here is a figure, and I know it's a little blurry probably on your screen, but it illustrates the percentage increase in suicide death rates for young people, 10 to 24 years old, by state. Okay, and at the top we have states like Maryland, Mississippi, Florida. Here we have the United States average. There has been a 47% increase for young people during this time period. But in Kansas, it's 60%, and in Missouri, it's 71%. So these numbers obviously are huge. We've been going in the wrong direction. And when we look at suicide and homicide death rates among our youngest, what we see is that we have had this huge increase for young people, 10 to 14-year-olds. Again, this is pre-pandemic numbers. Now, this study, the ABCD study, looked at 9 to 10-year-olds, and they're looking for risk and protective factors when it comes to addressing suicide. And what it tells us is when you look at the trajectory for young people, they've got almost 8,000 kids that they're following at 22 sites around the country. And they asked the young people, have you ever had thoughts of wanting to end your life? 8% say yes. Now, this is 9 and 10-year-olds, okay? Their agreement with parents tends to be pretty low. So if you ask kids if they've ever tried to end their life, you see that about half the kids who say yes, their parents say no. No, my child's never had that before. So, and other studies have really shown this as well, that parents are not always aware of how much their own child is struggling. That doesn't make them a bad parent, right? This information is difficult to ascertain. We know that psychopathology and child-reported family conflict were big risk factors, so they were predictive. And the children that reported a lot of weekend screen use also increased their risk. The child-reported suicidal ideation reduced with more parental involvement or supervision and positive school involvement. So I think that's important because certainly each child is unique and there are so many different factors. So this does not apply to every child. But when I think about the kids in my office who are struggling, one of the things I really try to push is involvement, trying to get hooked into an activity, something that you feel valued at doing. And parental supervision, of course, we know helps kids stay out of trouble too, and helps them have someone to turn to. Now, when we look at our emergency departments, I just had a virtual lunch with one of my ER colleagues yesterday, and I hear that they are extremely burned out. What we know is that they are fielding a lot of the mental health crisis. So in May of 2020, ER visits for suspected suicide attempts started to increase. The focus in the study is 12 to 17-year-olds, and they're presenting for a suspected suicide attempt. The time frame here, February to March, and they're comparing this past spring, 2021, to pre-pandemic, 2019. And what they found was that the visits have been 50% higher among girls. So a huge increase for girls during the pandemic. Among boys, 3.7%. So we're seeing, for some reason, at least for presenting to the ER, this is hitting girls harder. And this really corroborates that. So I know this is hard to see, but the top line, the black line, are suicide deaths for males, and the orange line are females. And the top here is 10 to 14-year-olds, and the lower line is 15 to 19-year-olds. And it's from 1975 to 2015. So what you see is there was this peak here in the early 90s where there was quite a disparity between the number of deaths for young boys and the number of deaths for girls. Basically what it means is we used to lose a lot more boys than we did girls. But this gap here is narrowing in the upper right. What we're seeing is we're starting to lose more girls. And I'll show you in the next slide why. One of the reasons why. There's lots of reasons that we can't get to today. So what we know in this study, it looked at youth suicides, a total of 85,000 during this time frame. 80% were boys. So overall, the ratio was almost 4 to 1. Boys to girls. The rate for girls declined until 2007, and then it had the largest percentage increase compared to boys, so increase of 12.7% for girls. So this ratio went from 3 to 1 to 1.8 for 10 to 14-year-olds. So basically, we're seeing more young girls having lethal attempts. And it really has to do with the method that they are using when they attempt, because many young girls are now using hanging or suffocation. And that is a highly lethal method. It's much more lethal than poisoning, for example. And so we are seeing more deaths. This again is a busy slide, but what we see here on this column on the left are firearms. We see there's a little bit of an increase in the ratio between males and females. For poisoning, it's been pretty consistent. But if you look here in the middle for hanging or suffocation, it's just what I was describing, that for the younger and the older set, we see this decrease in the ratio, that it's becoming closer to 1 to 1, that males and females are taking their life by suffocation or hanging. So a hugely important thing when we think about risk factors, and when we think about safe storage, how do we protect young people? It's difficult when the media is talking about deaths very explicitly with Kate Spade and Anthony Bourdain, and those are things that are not helpful for us. But how do we educate parents, I think, is a really important piece of the puzzle here, something not everyone talks about. So switching gears a little bit, a couple years ago, I was listening to the radio locally, and it was a show on suicide prevention for young people. And in the meantime, I'd heard a lot of these stories coming out that we are seeing increased risk of suicide among the young Blacks in our community and nationally. And yet, the journalist on this talk show said, "Oh no, we don't have a problem with suicide in the Black community. That's just not a thing we really deal with in the African American community." And I said, "What?" I was so upset because I thought, no, we can't perpetuate this myth. Now, historically, the African American community has had lower rates of suicide deaths than the white community, but that has been changing in recent years, and it's something we all need to be aware of, especially those of us that are working with young people and working with parents, to make sure that they are aware of this so that we can do something about it, so that we can make sure that our research reflects representative samples of folks and isn't just focused in one population. So what is this increased risk among Black youth? Well, what we know from a youth risk behavior survey is that the suicidal ideation and plans went down among U.S. adolescents between 91 and 2017. So thoughts and plans went down. However, attempts increased only among the Black adolescents. So if you just looked at the total number, you wouldn't necessarily see that. But when you separate out for our Black adolescents, you see this increase. For Black males, there was a bigger increase in injury by attempt. So they were using more lethal methods in those suicide attempts. We also see a really important age-related disparity. So the rates increased among Black children 5 to 11 years in these two time periods, while they were decreasing among white children. The rate was 42% lower among Black youths during this period. However, among children, our 5 to 12-year-olds, who we used to think did not have much risk for suicide, had a higher incidence of suicide compared to white children. So basically, we are losing more Black children than white children to suicide. And we need to better understand why, and we need to be able to look at our response and why is this happening, and how do we do something different to change it. So here is a graph from pediatrics, and they look at just those very examples that I gave you. So suicidal ideation in the past year, suicide plan, attempts, and then attempts that led to an injury. And they're broken down by different groups. So the purple line, which we know is high risk and we've known for years, are our American Indian and Alaska Native young people. The red line represents the Black population for young people. And the concern here is that we don't necessarily see them reporting suicidal ideation or even plans, but they have a big increase here in actual attempts. And so that's a big concern that we need to be looking at. Now, this paper just came out this week. I was really excited to share the findings with you because I think it may lead to some clues about intervention. And what they look at is that Black females in this study have had the largest annual percentage increase in suicide deaths, that's 6.6%, while the 15 to 17-year-olds have had a large annual increase. Only 35% of these young Black individuals who died by suicide had a documented current mental health problem prior to their death. So this isn't news to us, right? We've heard this before, that many people dying by suicide are not already in treatment when they die. But the precipitating factors, what was occurring before the suicide, vary by age group. So we're going to look at that. For the younger decedents, the younger set that died by suicide, we see they're more likely to have family problems, social crises, and problems at school. Whereas the older young Black people dying by suicide have more challenges with boyfriends and girlfriends, and recent criminal or legal problems. The diagnosis of those that do have a diagnosis also tends to depend upon age. So when we look at depression or dysthymia, we see that it is much more likely to be diagnosed among the older population here. Only 22% of the 5 to 11-year-olds carried a diagnosis of depression or dysthymia, of the ones that even had a diagnosis, right? Because the majority we didn't even have a diagnosis for. And this one, I think, is going to surprise a lot of folks. For ADHD, we see that 72% of the 5 to 11-year-olds carried an ADHD diagnosis. And why I think this is extremely important is that it's very common in healthcare when you are caring for a young person with depression to talk about suicide, to screen for suicidal thoughts, to talk to parents about how they store firearms and how they store medications. But do we consistently do that for our kiddos who never look depressed but present with ADHD? And I don't think the answer is consistently yes. And yet the research is telling us that these kids can be pretty impulsive and are sometimes making are in dangerous situations, making impulsive decisions that can be lethal. So we also know that the methods that are used vary by age and by sex from this study. So hanging or strangulation is the most common method used in Black youth suicides, and firearms are second. So that's different in other populations. It's very common for the girls that hanging is the most common method used. And firearms are used in 15% of girls and 37% of boys. Now, 92% of the youngest are using death by hanging as their method when they die, while firearms increase with age. So some areas for intervention here. When you ask the authors in their paper, what should we do about this? How can we respond? A couple suggestions I have. One is that historically we have done a lot of suicide prevention work integrated into school settings. And they say that perhaps that's not a good idea for this population. There's a lot of clear documentation that young African Americans are disproportionately disciplined harshly in schools. They're more likely to have suspension from school and may not feel very comfortable self-disclosing suicidal thoughts in a school environment, or may not feel like that's the place where they would ever broach this topic. So they pushed really more the idea of community-based interventions that may be better received. So Boys and Girls Club, the local church, any kind of community centers where programming could be implemented. They also really acknowledge that in the male African American population, there tends to be tremendous stigma with seeking mental health care, major barriers, and it can be very difficult. And there's often a push to really manage things more at home and not seek professional help. So they really encourage us to look through this JEDI lens, looking at how justice, equity, diversity, and inclusion principles can be utilized here, and that we really need to remember the trauma that many of our young African American individuals are facing in light of systemic racism and so many events that have happened in recent years. We know that if we just can't ignore that. You know, this is a part of what they are facing and experiencing, and it can certainly lead to barriers when it comes to help-seeking behavior. And this relates, of course, right, to social determinants of health. We know that this is how the situations where we live and work really contribute to and shape our health outcomes. And so this is multifactorial. This isn't just about the healthcare you might receive in an office. It's about what is your home environment like? What is your school like? All of it. And what we know is that if kids are experiencing violence in their community as an adolescent, that's going to increase their risk of depression, anxiety, PTSD. And then this study I thought was really important. It looked at communities that had experienced police killing of an unarmed Black American and found that young Black people in that community reported that their mental health was not as good. So the kind of distress that folks are experiencing, I think, is big. And we also have to remember COVID, of course, has disproportionately hit communities of color. So a lot of work to be done here, and certainly in research. I'm going to share with you later a research project I'm doing where I've met with some barriers. I know one of the speakers later today, Cecil, has tried to help me reach more people in the Black community because our research isn't solid, right? If it doesn't apply to everybody, we can't just research one part of our community. So this here is a survey I referenced earlier, and I think it's a really important survey. If you ever want good data, go to the Youth Risk Behavior Survey. It's an anonymous survey done by the CDC every 2 years of high school students. Over 10,000 high school students across the country complete the survey on all kinds of different topics. And what they tell us is pretty concerning when it comes to mental health. About a third of them say they felt sad or hopeless for 2 or more weeks. So that's really looking at symptoms of depression. 17% say that they seriously considered suicide. Now, the time frame for this question is in the past year when they answer it. So this isn't even lifetime, guys. This is in the past year, and this is average high school students. 13% say they made a plan for how they were going to die, and 7% say that they actually attempted suicide, while less than 2.5% saw a medical provider for the attempt. Now, this is the focus of my work, and I can tell you that this boggles my mind. And yet, when I interview kids who have survived a suicide attempt, and I've interviewed hundreds of them, when I ask them, when was the first time you tried to end your life? Often what I hear is, oh, last summer, I took a handful of fill in the blank pills I found at home. And I say, what happened? Oh, I got sick and I didn't tell anybody. I was embarrassed. So often kids aren't telling us, right? A lot of these suicide attempts are going undiagnosed. Now, part of our big concern here, right, even before pandemic, we were going in the wrong direction, that some of these numbers were going up. You guys see that okay? Great. Sorry about that. So we know things are going in the wrong direction, basically, and this is pre-pandemic. So keep these numbers in mind, okay? Now we're going to talk about our sexual minority youth, okay? The same exact survey. On the far right side here are the numbers I just showed you, okay? But here are the young people that are self-identifying as lesbian, gay, or bisexual. And what you see is that they are worse off in every category. That for symptoms of depression, twice as many are reporting these symptoms. Almost half have seriously considered attempting suicide in the past year. 38% made a plan, and almost a fourth say that they attempted, while 7.5% were injured in that attempt. So this to me is startling and is really a call to action for any of us that are working with any of these young people, because we know that they're at increased risk. Now, you also need to take note, I think, of this column here in between. Those young people who are identifying as not sure are somewhere in between. They're at elevated risk compared to the other kiddos, but not as high over here. Now, I'm going to hold off on this video until a little later. We'll see if we have time, but I just want to reference this, that I think the research is very clear that if young people who identify as gay are accepted by friends, family members, loved ones, their risk goes down. It's really clear cut. Having that acceptance makes a huge difference. So if you work with families that are struggling with this website has some really helpful videos. They're pretty brief for parents. And I think what it does is it can normalize for the parent, hey, we get that this is hard for you. This isn't the plan that you had in mind for your son or your daughter, but things can be okay. And I will tell you, I remember being a child psychiatry fellow at KU. The first time I had a child in my office, he was a teenager, self-disclosed that he was gay and he was suicidal. And he knew his parents were very religious and it was against their religion and he knew they would be upset. We ended up having him admitted to the hospital. And I remember taking part in that family meeting with Dr. Terry Smith, the psychologist. And I remember feeling very uncomfortable, like, how are we going to navigate this? And she really helped the parents to see how critically important they are in their son's life, and that they have to continue to find a way to love him and also manage their own emotions and their own reactions, because the parents were having a lot of distress personally about their son being gay. So it was a big learning experience. And since then, of course, I've been through this many times with other families, but I think this acceptance piece is really critical. The other thing we know, of course, is that our young people who are transgender are at elevated risk. So this was a national online study that looked at over 2,000 young people, 14 to 18. And the participants themselves reported the gender they were assigned at birth and also their current gender. So that's kind of a gold standard way of really clarifying if this young person is transgender or not. And what they found was that on every measure, with regards to suicide risk, they were at elevated risk compared to cisgender youth. The other thing is that they had higher risk for suicidal ideation attempt, as well as serious medical attempts. So what about policies? I think many times I tend to focus more on how I manage things in my office, and how do I send a message to my patients that I'm accepting and inclusive. But what happens outside of the doors of our offices often has pretty big implications, and I think it's important to at least be aware of this. So this is a study that looked at data from 47 states, and it evaluated the association between their same-sex marriage policies and adolescent suicide attempts. So they looked at that same youth risk behavior survey data that I was talking to you about earlier, and they looked at self-report of suicide attempt in the past year. Now, of course, what they found is that those suicide attempts were reported as higher for sexual minority youth before implementation of policies. But when the policies were implemented, so when gay marriage, for example, was allowed in Iowa, there was a 7% relative reduction in the proportion of these students attempting suicide, high school students attempting suicide. So this policy seemed to make a difference, particularly for the sexual minority youth. So those who identified as gay, lesbian, bisexual. Another issue here is looking at chosen name use. So this study looked at 129 transgender youth, and it measured whether or not the name that they wanted to be called was used for them at home, at work, at school, and with friends. And then they looked at their depression symptoms based off the Beck Depression Inventory, and also they looked at suicide risk. Now, use of chosen name in one context predicted 5.37 unit decrease in depression symptoms. So basically they had less depression symptoms just because their name was used in one environment. A 29% decrease in suicidal ideation and 56% decrease in suicidal behavior. So the authors really felt like this indicated that gender affirmation of transgender youth is critical, and many regulations are making this difficult. And by regulations, they meant, for example, if a child wants to use a different name at school, there's a lot of paperwork that has to be done. There are a lot of potential challenges or barriers to making that happen. Now, a lot of us have probably heard about pronouns lately. This has been a big thing. My 13-year-old daughter tells me how important it is that I ask all my patients what their pronouns are. But there has been increasing concern about gender-affirming care in the pandemic because many people have had less access to healthcare in general, but particularly when you look at what is considered medically necessary. For example, some surgeries were put on hold, and so gender-affirming surgeries were not accessible to some folks. So the authors felt like many people experiencing these delays may take this to mean that their care is not a priority. So another potential source of risk for them. Okay, so switching gears a bit, if you look at these folks putting their seatbelts on or driving around in their seatbelts, they look so blissfully happy, right? They are so thrilled and pleased to be wearing a seatbelt. And yet, if you're old enough to remember when seatbelts first came out, they were not so popular with everyone. There was tremendous pushback, and there was a lot of concern that this is infringing on my personal rights within my own car. But now it's legislated, right? And you can't leave a hospital in any of the 50 United States of America with a newborn unless they are properly restrained in a rear-facing car seat. Now, why is that? Because seatbelts save lives, right? The research is very clear on this, that we lost fewer people in motor vehicle accident deaths when seatbelts were instituted. Now, of course, seatbelts are not the only thing that made a difference, right? So Mothers Against Drunk Driving made a difference, and changes in our highways and speed limits made a difference, and anti-lock brakes. I could go on and on. A lot of changes came together, and now we're having to work on people not texting while driving. So it's an ongoing problem we have to address. But I bring this up because I think sometimes we need a little inspiration from the public health front on what has gone well and when people have made big changes and how many lives they've saved. Because when it comes to suicide, we have tremendous room for improvement, and yet we have some changes we could be making that we're not always doing. Okay, so this is a busy slide. I'm going to walk you through it, so don't get overwhelmed. Each dot, just blur your eyes, each dot represents a state in our country. Okay, so up here, upper right-hand corner, we see a cluster: Wyoming, Montana, Alaska, South Dakota. What do those states have in common? Well, those states, if you come down here to the x-axis, they have over 60% of household firearm ownership. So they are among the highest rates of homes that have guns in them in our country. They also just happen to have, if you go across to the y-axis, the highest rates of suicide for teenagers in our country. And so what you see is clustered down here. And of course, like, there's an outlier right here with Hawaii, but in general, the states that have the lowest percentage of firearm ownership, between 10 and 20%, also happen to have the lowest rates of suicide for young people. So I want to point something out. Many people will say, oh, well, that means that people that own guns are more likely to be suicidal. No, there's other studies that show that that is not the case, and they're not more likely to have mental health concerns. However, when people who have guns in the home have mental health concerns, they are more likely to die. And the reason is because firearms are so powerful, and they are more likely to lead to a death when they are used. So about 90% of the time when a firearm is used, the individual dies. That's why I can count on one hand the young people I've interviewed who have survived a self-inflicted gunshot wound, because they usually don't make it to the hospital. Okay, so where do we fall here in Kansas and Missouri? So here's Kansas and here's Missouri. We are consistently higher than the national average when it comes to deaths, and many people would attribute that to the many firearms that we have. Now, certainly not all youth die by firearm, but it increases our risk for sure. So this down here is what I call the goal. I used to call it my fantasy, and I've decided now it's an attainable goal. Now, if you notice, this is a pretty straight line here. I'm not suggesting we get rid of firearms. I don't think that is really a plausible answer. And I grew up as the daughter of a lifelong hunter with guns in our home. So I think firearms are a part of our community, and they aren't necessarily going anywhere. But I have yet to meet a firearm owner that thinks we should be cavalier about how we store our firearms. Most that I meet feel like they should be properly stored so that young people don't have quick access to them. And many people that I meet have never had anyone talk to them about that before. So I've talked to a father who is a survivor, who's a police officer, former police officer, who lost his daughter to suicide. And he says that she was good with guns. She was safe with guns. She knew how to use them. He never once imagined that she would use that gun to end her life. And he wishes that he had properly stored that firearm so that she wouldn't have had access to it. So I bring this up because I think it's something we often don't talk about, and we obviously have a lot of room to improve. Someday we could be the outliers on this graph, and people could say, what do they do in Kansas and Missouri? Why do they lose so few young people? And we could tell them why. Here's another reason why I think this is very important. This is a study that came out of Rochester, where they looked at 813 young people who presented with their first suicide attempt. And what they found was that 3.6% died by suicide during the follow-up period, but 71% of those died on their first attempt before turning 25. So many of those kids didn't have repeated attempts. They didn't come to our emergency department to get advice. Their first presentation to the healthcare system was their death. Males composed only 31% of the entire group. So males have fewer attempts, but they were the majority of the suicides. So when males do attempt suicide, they are more likely to choose a lethal method like a firearm. The vast majority of those first attempts were completed with a firearm. So the folks that died on their first attempt, it was with a gun. And 41% had no history of a psychiatric diagnosis. So again, we're missing a lot of these kids. And that's why I'm a big proponent of safe storage across the board, not just for kiddos that are identified as having mental health concerns, but for everybody, just like we wear seatbelts for everybody. I don't wear seatbelts just because I think that driver in the car next to me looks a little like a bad driver, right? I wear it all the time, just in case. And so that's how I talk about this with parents. But do families know to store firearms safely? Do we teach this? So this is a study that looked at what parents do. They asked parents, how do you store firearms in your home? And they asked a lot of parents. So they compared the families whose kids did not have any risk factors, compared to those families where the kids had either depression, ADHD, or some other mental health problem. And what did they find? There was no difference in how these families stored their firearms. So some would think, well, gosh, if you have a child with all these risk factors, you think that you might be storing your guns more safely. So either we're not providing that recommendation or families aren't hearing it. Something is missing here. From my perspective, this is some low-hanging fruit. If we could get to safe storage in our community, we could make a big difference. And if you've seen me speak before, I talk a lot about the Israeli Defense Force. Their suicide rate was cut by 40%, and many people attribute that by the soldiers not having access to their firearms on the weekends. So this is a really tangible change that could happen, but of course it takes a lot of effort. And it can be risky. There are some good reasons why people don't talk about firearms often. One of them is this example. So in 2018, the Annals of Internal Medicine came out with some guidelines for doctors. This is how you should talk about firearms with your patients and families. And the NRA put out a tweet that really made fun of doctors and said, you self-important anti-gun doctors need to stay in your lane. This is not your business, right? Don't get into gun control. Well, I don't know if any of you attended the firearm conference. It was actually at the University of Kansas a couple years ago, but Dr. Joseph Sakrin was there, and he was the doctor who started the reply tweet campaign to the NRA, and he said, oh, this is my lane. As a trauma surgeon, he had all kinds of, well, he's also a gunshot wound victim himself. So he was shot as a bystander as a teenager and survived and became a trauma surgeon. However, he and many others started tweeting out their own experiences and saying, listen, these are the bloody shoes that I wear in the OR when I take care of gunshot victims. And they had posted pictures. This is the room where I have to tell parents that their loved one has died in surgery because we couldn't save them. This is definitely our lane. So, and I wrote my own piece with Dr. Denise Dowd. She's an ER doctor at Children's Mercy, and Denise actually wrote the American Academy of Pediatrics guidelines on how we should address firearms with families. And we were writing a commentary responding to a study that had been published. And what we emphasized is, listen, as doctors, we are not necessarily firearm experts. That is not our role. We are experts in human development, in the teenage brain, and the fact that when someone is desperate and impulsive, they can make decisions that can be very lethal, and that as parents, we have to know that, and we have some opportunities to do some things differently. So just to show you here, what they did in that study that we commented on was they surveyed parents and adolescents, and they asked them the same questions. And the adolescents were asked, can you access a loaded gun in your house? And a third said, yeah, I could get a hold of one in 5 minutes. 23% said they could get it in 5 minutes. And that was in the homes where the parents said the guns were locked. Now, overall, 70% of the parents thought their child couldn't access the firearm, but 21% of their kids said they could within 5 minutes. So we see this disparity here that many times as parents, we think our kids can't do something and they can. But the other important thing here is that we got about 30% here that knew their kids could have access, right? And that's what I often hear is parents say, hey, I need my son to have access to that gun in case we get broken into. And so maybe they're putting a lot of weight on that security in the home and not really thinking about the risk within the home. It's a hard topic. It's not an easy one to address, but it's something I think that we could all be really working on. So if you want to talk about firearms with families, here are just a couple of examples from that Annals of Internal Medicine paper. One of the things that I've started doing is not asking. Some people are offended. They don't want you to put it in the medical record that they said they have a gun. Fine, I don't have to know if you have a gun. I just say, hey, firearms are really common in our community, so I'm trying to remember to talk to every family I work with about this. And then I just talk to them about the importance of storing them safely. Here's a mnemonic. If this helps you to remember things, it's really important that the firearms not be loaded. So if you're going to have them in your home, they should be locked up, unloaded, with the ammunition lock separately. Now, education. Can education alone improve safe storage rates? And this is a paper that really impacted my practice and the research that I'm doing now. So this was a review, and they looked at education and interventions. And what they found was that if you give people education and you give them tools to go home and make changes, they are more likely to do it. Makes sense, right? If you give me something free to actually make the change, I'm more likely to follow through. Only 25% of the time, if you just gave education, did they go home and make a change. So that's why I developed Prepped and Ready. So I developed this program. You see in the old days where we used to get together in person, I was up here in the front. I got to see everybody's faces, but it's good. I get to see a lot of your faces today, so that's nice. But I did this presentation for parents. We talk about lots of topics that are pertinent to parenting. So vaping and eating disorder prevention, the kind of things I see in my office, with a big focus on suicide prevention. And we give out a handout so you can take it home and share it with the person if you parent with someone else at home or a grandparent. And then we give tools to help implement changes. So this lockable medication storage box to put those big 90-day supplies, and 4 weekly medication boxes with a Ziploc bag full of kitty litter to properly dispose of your old medicines. You're supposed to mix it with kitty litter, coffee grounds, dish soap, something animals don't like to eat. And then I partnered with the Lock It for Love program, and they gave out free quality cable gun locks for parents. So with that, what we've learned so far from our live in-person presentations is about 38% of the families that participated said they had guns at home. Now, we were most concerned about getting parents to store their firearms more safely. So what we found is that the odds of storing them in the safest manner possible, locked up, unloaded, ammunition locked separately, increased 5 times after participating. And the presentation is less than an hour, so it's not a huge chunk of time. But the other thing I loved was that almost 40% said they went home and they learned more about storage after the presentation. So could it be that the person in your office isn't the person that's the firearm owner or not the one responsible for the firearm storage? They may not know the answers if you're asking them how things are stored, but I think it's about starting that conversation and giving them some of the language. So what I have learned, we went with the pandemic to a webinar format. Many parents, especially single parents, parents that are juggling a couple jobs, they do not have time to sign on to a webinar at 7 p.m. I mean, we've had hundreds sign on. It's been great, but we really want to make this scalable and accessible to as many parents as possible, or not just parents, people raising young people. And so we've developed a series of videos. And the fun part about that is I can include ICU doctors and ER doctors and social workers, other people, because I didn't have to reserve them for 10 nights of the year because they could be on video. So it takes about 45 minutes to watch the videos. And if the participants actually fill out our surveys and they give us their address, then we will mail them a toolkit. So we've been really lucky with some generous philanthropic donors who are funding that, because of course when the pandemic hit, I didn't have the money to all of a sudden mail these heavy toolkits to everybody, but they are helping with that. Now, one of our goals here is that we really want to reach more men, more people of color, and more firearm owners. We have struggled to reach those folks. And so if you in your community know of people that might be interested, please, you could put your email in the chat and I will grab it there, or you can send me a message. I'll have my email on here. We'll be updating our release date very soon on the Children's Mercy website. We're just waiting on some final deliveries. So these are some quotes from parents who participated in Prepped and Ready previously. I wish I'd known to lock up meds before my child attempted suicide by overdose. I wish I had received this presentation 2 years ago. This course not only helped my family, it provided me with the courage to report a concern we had with one of my daughter's friends. As parents, we need to be open and realistic about what our kids are experiencing. I truly believe that this information could save the life of my child. I have started locking everything, and honestly, it has improved my health. Time well spent to save my child's life. I wasn't even aware of all the guns in my home, and my husband had forgotten about an unlocked gun he had in the house. We went home and reduced access immediately. Thank you. So these are my children, real excited that you might help me spread the word about Prepped and Ready. Here's my email if you're interested. And reaching out to me. Our communications and marketing people have been amazing, and they've made some little bite-sized commercials that could be shared on social media about Prepped and Ready. So if you're interested or willing to share some information, I can just share it with you, and it will be super easy to do. So with that, I'm going to stop and see if we have any questions. I've also got my references here if anybody needs those.
I do think people were hoping for resources. That was amazing, super insightful, very helpful. Love the just practical actions we can all take to keep our kids safe. So many things that I think we walk through everyday life because we're all busy getting kids hither and yon and practice and school and everything else, and we forget about these small things we can do to make a huge impact. We did get, let's see, Marianne, I know that you had just asked about her email, and Dr. Sullivant, was it ssullivant@cmh.edu?
Yes, I'll put it in the chat.
Oh, that's wonderful. Thank you for doing that. Somebody did ask, does the data show differentiation between pandemic and political unrest as far as stressors?
Well, here's part of the challenge, and I think most people that work in this field are just so frustrated. The data always lags a couple years, and so it's hard to get updated data. 2019 data did come out nationally. I haven't seen it well broken down for children, but I've seen for the adult data, they've shown some decrease in suicides. But many people would say it's really hard to know for sure because there's been some real increases in ingestions or opiate overdoses, and sometimes it's hard to know how those are labeled, if they're labeled appropriately, because it's hard to know after someone dies. And when you talk to the ER doctors, they're under a lot of pressure to not label something as a suicide. It's really a very delicate and painful situation, of course. And so I think it's hard to get good data. But I think we know there's been distress, and certainly like there was a paper that came out of Chicago that they were seeing a big increase among the people of color, and it was adults with regards to suicide. So I'm afraid we're going to be seeing some pretty bad news in the coming months.
Okay, thank you. Is there rationale behind why there's so much pressure on our ED providers to avoid using the term suicide or labeling deaths as suicide?
Well, like in my video, you'll see Dr. Dowd shares the story of the first time that she pronounced a young person in the ER as a doctor, and how this was a young man who had a self-inflicted gunshot wound, and his girlfriend had broken up with him. And I think it's really hard to imagine the shock and distress that family members go through in this situation. And it can just be unbelievable for them often. And often what we hear is, well, my child is good with guns. I've had many parents say this to me. I'll be in the ICU with parents of a child who has overdosed, and I will go through my typical approach of all the things we need to do at home to assure safe storage. And they will say to me, you think my daughter's going to shoot herself? And and I have to be real cautious. Like, no, I don't think she's going to. I never want her to have the opportunity to. And she's just shown us that she's really in a desperate, bad place. And so I want to make sure we do all the things we can to help her be safe. But I think it is one of the hardest things for people to wrap their brains around. I've told people before, try to imagine the person you're closest to, and then imagine that this happened and you didn't know it was coming. It's just kind of inconceivable, I think. And so I think that's often what the doctors are facing, is families who are not seeing that as a suicide as a potential cause. Certainly, often families see it. Every situation is so unique and different. But one of the things I always emphasize to folks is this happens to the best parents on earth. That I see the best families in my office. I mean, just such caring, loving people. I see them in the ICU. So to me, it's not about being a good parent. I think that suicide is multifactorial. There's so many different aspects that come into play here. And we don't control the factors that our children face, or, the world that they face. But there are some concrete steps of things we can do that have shown to save lives.
Great, thank you very much. I know Joe Carlin this morning spoke a little bit to his belief that social media has obviously had a tremendous impact on youth, adults too, but certainly in the demographic that you're speaking to. Can you, since we have a few minutes left, speak a little bit about the influence of social media on the mental health of youth and adolescents?
Yes, I think it's huge, and I just didn't have time to include that today, but I think there are some charts. If you look at when the scale tipped and more than half of teenagers had access to a smartphone, is right around the time that you see these big increases happening. So, and there's other studies that show for young girls, I mean, like I'm sitting in the eating disorder center right now at Children's Mercy Hospital, where I am every Tuesday, and our numbers have been through the roof. I mean, we've never gone through a time like this where we have this many referrals. I think that there are a lot of aspects to social media that can be positive, right? So if you live in a small town and you feel like you're the only person in the world that's gay, and you reach other people online for a support group, that can be really positive and very affirming and helpful. But there are so many other aspects, I think, that we know can be damaging. I mean, just some of the cruel things that kids say to each other on social media. I mean, you've all heard it and seen it. It's terrible. And I think he said that this morning, that kids used to get left out of the party and they didn't have to hear about it all evening. And now sometimes they watch on social media as the people they hoped would be their friends are at a party together. So it's atrocious. I try to tell parents, as long as you can avoid social media, the better. I understand that you can't avoid it forever, but I certainly think for the youngest set, it's not healthy.
Yeah. It is tough going out there for sure. We did just have somebody drop a question in the chat referencing the fact that suicide by girls has increased with hanging or suffocation. Are there measures that people can take to keep the home safe for those kind of risks?
Yeah, that's a really hard one, and I think we don't talk about it enough. So once in the hospital, I took care of someone who had an overdose. And I always ask, have you had any other thoughts of what you might do? And he said, yeah, I thought about hanging myself. And he had asked his mother to take him to Walmart to buy a rope. And I remember the trainee sitting next to me said, oh, I can't believe that. I can't believe the mother did that. And I said, well, do you educate parents about risk of hanging? I don't think it's typical. I think we're all uncomfortable with this topic and not sure how to address it. So what I would say is I always try to identify if someone has ever had those thoughts, I want to make sure their parent knows. I want to make sure they have an open door policy so that when Susie gets in trouble and you take her phone away, she can't go up to her bedroom and slam the door, because you need to lay eyes on Susie, right? If she doesn't come down for dinner, you need to be checking in on her and seeing what's going on. But I had someone who had had thoughts of hanging and wanted to take the new dog with its leash on a walk out in the woods behind their house. And I said, no, not unsupervised. You've got to have an adult with you. So there are things, I mean, I have told parents to put ropes away, but it is difficult to proof your home of all the things that could be used in a death by hanging. So I think those are some of the measures often they happened after a fight, after a disruption, after, they got in trouble at school. And so sometimes we talk about, you got to hang out in the living room tonight. You don't have to talk to us, but you're going to have to be around folks. We don't want you to be alone right now.
Great, thank you. That was good clarification. I think one more. I know we're at 2:10, and we'll take a brief break. Somebody was asking about advice for proactive interventions for kids with ADD or ADHD.
So I think safe storage is one of the most important ones. And I think trying to work with kids, not just with medication, but on coping strategies to manage distress, I think is really big. I mean, the mindfulness meditation I thought was a great example of we've got to help kids learn how to tolerate distress. And that means stepping away from a situation and taking breaths. It has to be at a developmental level, right? So there's Moshi Twilight, that's geared towards little children. And then there's things that are geared towards more adults. But I think that's a really important piece of it. But then also within our homes, I think not leaving Joey home alone when he's in a really bad place emotionally. Having that supervision, locking up our firearms, locking up our medications, I think those could definitely help prevent some situations.
Perfect, thank you. So insightful, so practical, so helpful. We really appreciate your time. Thank you for getting the afternoon kicked off in such a great way, Dr. Sullivant. We appreciate you. Thank you.
Thank you.